Kira, everyone, I couldn't be with you today, so I have recorded this face-to-face tutorial. Let's start. In this first case, I would summarize the presentation of Mr. Buckley as a 70-year-old man with a 1-year history of prostatic symptoms, including urgency, hesitancy, and incomplete emptying. This is affecting his lifestyle. He's come because he wants to attend his daughter's wedding and wants help with the symptoms. Okay, so let's think about what is prostatic hypoplasia. So the prostate surrounds the urethra, and as it enlarges, it means that the bladder neck and the urethra are compressed and there is decreased flow. How can we help this? Several important points. So the first thing is that this isn't cancer. He doesn't need cancer treatment. There's no increased risk of cancer. So we can reassure Mr. Buckley that he doesn't have at the moment anything to be concerned about cancer, though it might want to be further investigated maybe at another time. What can we do? Well, the prostate can be shrunk in size, and if it shrinks, then that can increase the flow. But the way we shrink it takes a little time. Excuse me. What we use is a drug called Finasteride or Dutasteride, okay? And here they work because they inhibit an enzyme called 5-alpha reductase. And 5-alpha reductase changes testosterone to the more potent dihydrotestosterone, which acts on receptors and causes hypoplasia of mostly the stroma, a little bit of the epithelium, but mostly the stroma. And that can take to 6 months to work. So good long-term, but not going to be helpful in a month for his daughter's wedding. The other thing that we can do is relax the smooth muscle. Okay, so there is a series of drugs called alpha-1 selective alpha blockers, and these relax the smooth muscle in BPH, and so they can increase the flow and improve obstructive symptoms pretty much immediately. So you probably, for this chap who wants to go to his daughter's wedding, that might be the one that you choose. Now, there are side effects, of course. If you do choose to have a smooth muscle relaxer, you can imagine that there might be an increased tendency to hypotension and fainting, and he might want to be warned about a range of side effects to do with that. The range of side effects associated with finasteride is his baldness might improve because it can also be used as an anti-androgen drug for hair follicles in the head. Okay, so we've discussed the drugs and moved straight along to the next case. Okay, so here we've got Mr. Fisher. Mr. Fisher is a middle-aged man. He has acute onset of frequency and burning in his urination, suggestive of an infection. But this could be a urinary tract infection, but he's also complaining of pain in the perineal region, which might suggest that he has not just a simple urinary tract infection, but also that he has prostatitis. Okay, so he appears to be at low risk of having any sexually transmitted infections, and that is an important thing to ask when you're thinking about prostatic infections. Right, he doesn't appear to have a systemic illness because his temperature is normal, his blood pressure is normal, his heart rate slightly elevated, but pretty normal. And when we examine him, he's got a very tender prostate, which confirms that the most likely diagnosis is prostatitis. And the urine dipstick is positive for white cells and nitrates. So I guess the point of this history is that not everything that causes frequency and burning on urination is a simple urinary tract infection. It can be prostatitis. All right, so that was the diagnosis. What is the most likely organism? Usually a gram-negative like E. coli would be like with any urinary tract infection. But again, I want to emphasize that the sexual health history needs to be taken. All right, so what is the recommended treatment and why? So what does either empiric or health pathways say? I have an Apple phone, so I can't download the Empiric app. If you have an Android phone, please download the Empiric app and it will help you choose antibiotics. Okay, so going here, I will check the answer. All righty. So you should start empiric treatment while waiting culture. So it's likely to be an E. coli. So the first line treatment is trimethoprim and sulfamethoxazole for 4 weeks, or ciprofloxacin for 4 weeks. The reason that it is a long course is that it's really hard to get into the prostate to get rid of the organism. If you think of the prostate as a bit like Swiss cheese, it's got some quite big glands in it. They're filled with gunge, and the bacteria can persist in there quite a long time. Okay, remember that nitrofurantoin isn't an appropriate thing to use because the concentrations in the prostate is subtherapeutic. This information came from Health Pathways. Okay, so in summary, we're understanding that the prostate can be infected, that the natural history is that it is persistent infection and it needs a long course of appropriate antibiotics to treat it. Let's think about this third case, Mr. Faulkner. He's noticed a lump above his left testicle, which he describes as boggy. How long has he had it for? Oh, sorry, he just noticed it straight away. So it's an acute presentation in a young man of a non-tender mass superior to the left testicle. Notice it's superior to it. It's not part of it. So an appropriate investigation would be ultrasound, which he has. And so we have a normal testis, a varicocele, which is congested vessels, as you know, lying adjacent to the testis, which is normal in many men, and a cyst on the right side of the epididymal head. Okay, so far so good. You can get cysts in the epidermis. They're benign. They're just like a retention cyst where the testicular secretions get retained and it forms a hollow cyst. But there's something else here. There is a relatively small 10-centimeter mass in the lower aspect of the right kidney. Now, a lot of kidney tumors these days are incidental omas. They're discovered incidentally when people are being investigated for other things. Now, it's quite common, for example, to have partial nephrectomies. What's really concerning about this, though, is that he's very young, right? So the normal renal cell carcinomas happen in people usually over the age of 50, and he's very young. So we wonder what's going on here. We aren't so concerned really about the testis because he appears to have a simple epididymal cyst. But what's going on in the kidney? If we look at the ultrasound, we can see that it's a well circumscribed solid and cystic mass. So ideally, this would need to be removed in a partial nephrectomy. Okay, here's the CT. So we would always do a CT just to stage it, and you can see well, I said small, but it's actually quite a large mass coming from the bottom of the kidney. Okay. All right, so the patient has a varicocele and a cyst, which is probably the epididymal cyst, the spermatocele. And I've explained the definition of those to you. Are they connected to the renal mass? No. No, the renal mass was discovered incidentally. So what's our definition? What's our differential diagnosis of the renal mass? So number one is always a tumor, okay? And then we have to try and decide what kind of tumor it is. So most tumors in the kidneys are epithelial tumors. And in young people, there can be tumors that have a lot of renal tumors have well-defined genetic things in them, and so we can define them by that. However, most often we don't. Most often we do immunohistochemical stains and we look at the morphology. But there is a set of tumors that is related to a specific translocation that does happen in young people. So I would think it would either be a primary tumor, which is most likely, or it could be a secondary tumor. Could it be anything else? Probably not. Okay. So here we go. So he had his kidney tumor removed and it looked like this. And the kidney tumor has a characteristic appearance, which suggests that it is one of these translocation carcinomas. So how do we confirm it? We confirm the translocation doing FISH by using what's called a break apart probe. So in normal people, if the two areas that form the TFEB gene are close together, they form a single yellow dot. But here they've broken apart and we can see that they are now showing as a red and green dot. So we know that the normal chromosome bits of TFEB have come apart from each other in the translocation. So if this man has children, will they inherit the mutation? Well, this depends whether or not it is a somatic or a germline mutation. So if it is a somatic mutation, which it could well be, then no, they won't inherit it. But sometimes these mutations can be germline, so he will need to be investigated by the genetic service. Okay, so that brings us to the end of the workshop. Thank you.